So, good morning to all. Today I'm going to teach about alopecia. What is alopecia? Alopecia is nothing but reduction in the number of hair follicles, and there is in other terms it's called hair fall, like that. It's broadly classified into cicatricial and non-cicatricial alopecia. Cicatricial is nothing but it is permanent loss of hair follicle, or destruction of the hair follicle, while non-secondary alopecia, it is reversible type of hair loss. Here, there is a possibility of hair to be grown in the future. Okay, so we can subdivide that into alopecia, cutaneous alopecia, and non-secondary alopecia. Under non-secondary alopecia, it is there are few. One is anagenetic alopecia, which is due to hormone influenced hair loss. The next one is telogen effluvium. It is a cell type of non-secondary alopecia type of hair loss. It is due to chronic stress or iron deficiency or any fever, trauma. It follows a period of 3 to 6 months. And next one is anagen effluvium. It is due to any introduction of any chemotherapeutic agents. So, so before going to the topic proper, we have to know about the anatomy of hair follicle, as well as hair cycle. So hair follicle contains three parts. Main first one is the infundibulum, isthmus, and the hair root. Okay, so there is a period between the hair follicle and between the sebaceous gland. It is isthmus, and above that is infundibulum. The hair follicle stem cells are present at the junction of sebaceous gland and uh, isthmus. So if there is any destruction causes to the hair stem cells, it causes secondary type of alopecia. Whereas the hair follicle stem cells are preserved in non-secondary alopecia. Okay, good. So the term secondary alopecia is derived from Latin word which is cicatrix, meaning is scar. Okay. Cicatricial scar in type of alopecia includes a group of disorders leading to permanent hair loss, whereas in non-cicatricial alopecia, the hair stem cells are preserved and there is a reversible type of hair loss. Cicatricial alopecia can be classified into primary and secondary. Primary, it specific the target destruction of hair follicle unit. The cause is unknown. The secondary alopecia, it occurs as collateral damage to non-specific disruption of the dermis. And there are few subtypes. First is inflammatory and inflammatory. There is lymphocytic. Uh, there are few. One is chronic cutaneous lupus erythematosus, lichen planopilaris, which is LPP. Under LPP, there are subtypes. First one is Graham-Little-Piccard syndrome. Second one is the frontal fibrosing alopecia. Graham-Little-Piccard syndrome, it is a cicatricial alopecia of the scalp and non-cicatricial alopecia of the axilla along with follicular papules. Under frontal fibrosing alopecia, the hair follicle is mainly around the frontal area. There's they call pseudopellar of Bragg. Central cicatricial alopecia mucinosa, keratosis follicularis, spinosa decalvans. Under neutrophilic type, first one is follicularis decalvans, and next one is dissecting cellulitis of scalp. Under mixed type, first one is acne choroidalis, acne necrotica, erosive pustular dermatosis, and last one is non-specific or end-stage cicatricial alopecia. Under secondary cicatricial alopecia, first one is radiodermatitis, mechanical trauma, post-operative, for example, during flap necrosis, burns, accidental alopecia, dermatitis artifacta, tractional alopecia, hardcore alopecia. And there are few sclerosing disorders, morphe, scleroderma, lichen sclerosis, sclerodermoid, parphenocutaneous chronic graft versus host disease, and granulomatous such as sarcoidosis, microbiosis lipoidica, and infectious granulomas. And infections, there are bacterial folliculitis, carbunculus, furuncle, fungal infections such as inflammatory such as Kirian and Favus. Under neoplasia, there are adnexal tumors such as Syringosystema bactifram, and malignant type. There are uh, primary such as basal cell carcinoma, squamous cell carcinoma, and cutaneous T cell lymphoma. And development defects and hereditary disorders, personal aplasia cutis, facial hemiatrophy, which is called Rombock syndrome or Pari-Rombock syndrome, epidermal nevi, half follicular hematomas, incontinent pigmenti, which is a X-linked disorder which causes pigmentation along the bulla pigmentation along the Blaschko's line, focal dermal hyperplasia of balls, porokeratosis of mobili, ichthyosis, Epidermolysis bullosa, polyarthritic fibrous dysplasia, Conradi-Hanerman syndrome, and last one is condylar dysplasia punctata. So here we can see the pathogenesis mechanism of primary secondary alopecia. It includes first the primary theory is hair follicle stem cell dissection. So stem cell dissection theories. Second one is the collapse of hair follicle immune privilege. So hair follicle is a immune privilege type. For example, in alopecia areata, the hair fall is due to the inflammatory cells attacks the hair follicle, but it's past the stem cells, so it is a not a cicatricial type of alopecia. Whereas in other types, there is permanent loss of hair, alteration of lipid metabolism, neurogenic inflammation theory, environmental and genetic factors. First, we can see lupus erythematosus. Lupus erythematosus is classified into acute type, subacute CLE, and chronic DLE. So, secondary alopecia is most commonly seen in pseudoscarp erythematosus. This is a chronic LE. The clinical features includes which predominantly involve 20 and 40 years of disease, second and fourth decade, and most common in women. So all the immunocompromised, all the autoimmune disorders are more common in female. So it is female. So the disease most commonly affects the scalp, face, and ears. The lesions are well circumcised, round, oval erythematous scaly macular papule, which enlarge into a discoid alopecia patch with erythema and adherent scaling, which when I remove the scaling, we can see carpet tack appearance, or you can say tin tack or cat tongue sign on undersurface of the skin. So you can see the image which is shown the left side. So you can see the patch as well as scaling, and you can see the follicular hemorrhages. The combination of motile hyperpigmentation at the periphery, telangiectasis, and follicular plugging in the areas is highly characteristic. So histopathology shows hyperkeratosis with follicular plugging, perivascular and periadnexal inflammates, focal basal layer vacuole degeneration, which is the interface changes or interface dermatitis pattern is seen there. So thickening of basal membrane zone and exocytosis of lymphocytes into epidermis and follicular epithelium. So the histopathology images clearly shows the follicular hyperkeratosis. You can see the band-like infiltrates, the vacuolar generation of basal cells. So correctly called interface dermatitis. Mucin can be seen in the dermis between the collagen bundles. Scarring occurs due to deposition of homogenized collagen fibers, which is parallel to the surface, and loss of appendages. So elastic fibers are absent from the scar. So going to the management part, the first side of treatment element is sun production and potent topical interaction steroids. Can inject ILS interaction steroids. Other topical agents are tacrolimus, tazarotene, and imiquimod. Antivirals can give hydroxychloroquine HCQ 200 to 400 milligram per day for 3 to 6 months are effective in daily. So before doing HCQ, you should do you should get after opinion. So bullseye maculopathy and the other field vision changes are much more common in mechanism effect of HCQ. Next one is lichen planopilaris. This is the most common form of follicular lichen planus and typically presents with progressive scarring alopecia scalp. It is most commonly confined to the scalp, but it may occur in other areas with or without concomitant or scalp involvement. So pathogenesis, as we earlier discussed, there is progressive loss of peroxisomes, which later there is accumulation of inflammatory lipids, which later there will be infiltration of inflammatory cells and loss, destruction of phyllosebaceous sebaceous unit. This causes the permanent hair loss. Clinical features, scalp lesions may show violaceous papule, erythema and scaling. These papules are quickly replaced by follicular plugs and scarring. These plugs are shed from the scarred area, which remains white, smooth, and atrophic. Follicular orifices are absent within the area of alopecia, with the patches extending. The horny plugs may still in the hair follicles around its margin, and the hair pull will be positive at the margins. So we can test what is a hair pull test. So it is a clinical test to look for the activity of the hair fall. If the hair pull test is positive, disease is still active. So how to do? We have to pinch the hair with the non-dominant hand. We can pin almost 60 to 70 hairs at the margin of the hair for the hair loss. If the hair comes from the area, almost if the hair comes more than 10% in person, is it positive? It indicates the activity of the disease. Sites of LPP other than the scalp, it may involve the axilla, inguinal folds, sacrum, and lymph plexus. It presents as a group where disseminated follicular flat, elevated, and erythematous papules or punctate keratosis. Histopathology, early stage. In epidermis, buildup changes in the basal cells lead to the formation of colloid bodies. Macrophages containing pigment may be seen in the dermis. In established lesion, the horny layer and granular layer are thickened, and there is irregular acanthosis. There is flattening of retipex, which gives you a shorter configuration. There is liquefative degeneration of basal cells. In the epidermis, you can see the staples in the dense influence of lymphocytes and histiocytes. And next type is frontal fibrosing alopecia. So it is a subtype of lichen pylopilaris. It typically occurs in the postmenopausal woman. The clinical features includes recession of frontal hairline. This is the cardinal feature of frontal fibration or alopecia. So this word is very, very important. Recession of frontal hairline. Itching may and pain may occur, but it is often absent. Loss of eyebrow, so it's like a very characteristic and early finding. There is a loss of hair follicles orifices and perifollicular erythema and hyperkeratosis at the margin of hairline. So management, there are a variety of treatments included. Topical and can give topical steroids, international steroids, HCQ, doxycycline, but the what is unsatisfactory. The prognosis is very poor. Next one is Graham-Little-Picardy syndrome, GL syndrome. So most commonly in females with the age group of 30 to 70 years. The essential features of the syndrome are there is progressive alopecia of the scalp and loss of pubic and axillary hair without scarring. There is a scarring of scalp, but there is no scarring type of alopecia in pubic and axillary region. And you can see that the follicular papules and the development of keratosis pilaris. So it's the pathology is same as the previous one. In the scalp, the affected follicles are filled by horny plugs. The underlying follicles progressively destroyed, and eventually an atrophic epidermis covers sclerodermis. In the axilla and pubic region, the follicles are destroyed. The skin does not appear clinically to be atrophic. So management part. So you can give a short course of oral prednisolone to stabilize the disease. You can use cyclosporin, cyclosporin. You can give protein topical steroids and sick with iodamide. The next one is pseudopelade of Brock. It is a disease of exclusion. Okay. After ruling out the previous ones, we can't find the diagnosis now. You can think of pseudopelade of Brock. It has certain features. So it is a idiopathic, chronic, progressive, patchy secondary alopecia that occurs without any evidence of inflammation. That is a clinching point for pseudopelade of Brock. The clinical features include the alopecia is asymptomatic because there is no inflammation, there is no pain, there is no itching, and is often discovered by chance. On examination, the patches are smooth, soft, and slightly depressed. So pathophysiology is the same as before. There will be lymphocytic infiltrates around the two-thirds of hair follicle, including the hair bulge. The hair bulge is the site of presence of the hair follicle stem cells that spars the epidermis and eccrine glands. Later, the patches are smooth, soft, and slightly depressed, and histopathological reveals only a thin atrophic epidermis, low acidic dermis, and containing fibrotic streams that extend to subcutaneous. So there is no inflammation. Earlier, you can see inflammation, but once the disease is progressed, there is no inflammation. Okay, this is the diagnostic criteria of pseudopelade of Brock. So the clinical criteria, it is irregularly defined and the confluent patches of alopecia. There will be moderate atrophy in the later stage, and in early stage you can see peripheral erythema. It's most common in females of ratio 3:1. It carries a long course. It carries more than 2 years. It has slow progression with spontaneous terminal possible. Historical criteria. So there is no marked inflammation. There is absence of widespread scarring. Can best seen with the Aspen stain. Okay. Absence of significant follicular plugging. Absence of disease. At least decrease of sebaceous glands. Presence of normal epidermis. And there is only occasional atrophy. So fibrotic streams in the dermis. As there is no inflammation, the immunofluorescence will be negative. There can be weak IgM due to sun exposed site. So management, alopecia is irreversible. We can't and usually doesn't respond to topical or interaction corticosteroids. No treatment is known to arrest progression. The prognosis so poor. If the displacement experiment is present and no activity changes, autografting are can be considered. So next type is central cicatrizing alopecia. It is also called hot comb alopecia. Okay, it is a form of scarring alopecia that mainly affects someone of African ethnicity. It begins as a focus of cicatrizing alopecia over the vertex of scalp that gradually spreads outwards in a centrifugal pattern. So it's a name called centrifugal cicatrizing alopecia. Dramatic hair practices also called outcome alopecia due to use of hair dryers. Histological identification, you can see premature degeneration of the inner root sheath. So this is the image that depicts a central cicatrician alopecia, hardcore alopecia. It causes permanent hair loss that begins with the central crown of the scalp and widens over time. Central secreting alopecia, especially over the female woman, black woman, you can patient may experience burning, itching, tenderness. Can examine tenderness and scaling and acne bulbs on the scalp. So some people they won't experience any symptoms. Uh, it carries the stages. In the initial stage, there is subtle thinning in the central crown, and the stage progresses. There will be increased thinning and central scarring. In the later stage, there will be severe bone loss and scarring. So treatment of secondary alopecia is dependent on the disease and for focus on relieving symptoms, promoting hair loss that are not permanently scar. So you should ask the patient to you avoid uh, hair combs, not hair combs. So pathophysiology, the same as we discussed before and earlier. A central superficial perivascular and peri-inflammatory interface is as in active areas. There is no associated interface change. Sebaceous glands are lost early, but the eccrine glands are spared. There is premature disintegration of inner root sheath. In really pictures, it is this alopecia is slowly progressive and symmetrical, central on the crown with forward progression. It follows a pattern similar to female pattern hair loss. So management, minimal hair grooming is recommended. So there is, you should do culture for occult tinea capitis is recommended. Potent corticosteroids may arrest progression, and doxycycline minocycline is useful in inflammatory cases with pustules. So keratosis follicular is decalvins KFSD. It is a rare genetic heterogeneous syndrome. Inheritance may be X-linked dominant with mutation in the spermidine acetyltransferase gene at XP22 chromosome, or autosomal can be autosomal dominant. So it is usually begins in the infancy and childhood. It is characterized by extensive characteristic pilaris and progressive secondary alopecia. We can see the spiny necrotic lesions initially on the scalp and later progress to eyebrows, eyelids, and limbs. The disease tends to progress until puberty with patchy and secondary alopecia on the scalp, eyebrows, and eyelashes. Other associated features are palmoplantic adenoma, punctate corneal epithelial defects, ophthalmitis, photophobia, and facial erythema. Next type is alopecia mucinosa. It can be primary or secondary to lupus erythematosus, mycosis fungoides, angiolymphoid hyperplasia. Clinically, you can see dilated follicular orifices, keratin plugs, can be now seen over the scalp and face associated with lymphoid pruritus. Hair shafts are usually fragile and breaks easily. The alopecia mucinosa confined to head and neck. Histopathology, we can see the for reticular degeneration of epithelial cells, the sebaceous glands and outer reaches, with later disruption of these cells with the formation of cystic spaces. It is usually formed by accumulation of mucin within the hair follicles and sebaceous glands. It's stained metachromatically with the gemstone and alopecia blue. So treatment is the same. Oral corticosteroid minocycline acetylene has shown to be effective, but the overall prognosis is poor. So follicular decalvans. So if it is characterized by follicular inflammation with later dissection of the hair follicle and scarring alopecia, this is commonly occurs between the age group of 30 to 60 years, and both sexes are equally affected. It is due to chronic bacterial folliculitis or altered immune responses. Coagulase positive Staph aureus is often recovered. Skin features. So the inflammation is around the hair follicles of the scalp in the form of pustules, followed by extrusion or suppression and crusting. Peripheral extension scarring leads to patchy secondary alopecia. and complete lack of symptoms, and it carries a chronic course. Resistant to treatment with unfavorable prognosis. You can see tufted folliculitis is a variant in which of tufts are rare, or the cardinal feature of common feature. The multiple act of emerge from a dilated auricular is called Dolcer. Histopathology, you can see the early lesions of a peri and intrafollicular neutrophilic infiltrate, its few lymphocytes, histiocytes, and plasma cells. And older lesions, they can see a grounded granule tissue containing numerous plasma, lymphocytes, and fibroblasts. So treatment, the topical can give interaction steroids, triamcinolone. Topical antibiotics such as clindamycin is useful, and topical can give topical steroids. And oral treatment includes clindamycin 300 milligram BD plus rifampicin 300 gram BD for 7 days. Or you can give ciprofloxacin and levofloxacin 500 milligram BD for 7 days. Or you can give dexamethasone tablet 0.1 milligram per kg per day for 2 weeks, 2 days in a week. So visiting the scalp, it's a rare chronic folliculitis of the scalp, presenting with painful separating nodules, interconnecting sinuses tracts, false swelling distal, and extended scarring. Although streptococcal pseudomonas propionectomy may be cultured from the various lesions. A defect in the follicular organization results in portal obstruction and accumulation of sebaceous and carinaceous material in the sebaceous units. The initial units are painful, indurated, skin-colored nodules over the vertex. The tubular ridges are formed by coalescence of confluent nodules, leading to irregular cellular film pattern. Pathology, you can see the dense, small, perifollicular mixed inflammatory infiltrates of lymphocytes, histiocytes, plasmacytes, and neutrophils, affecting the lower half of epidermis and subcutaneous fat. Treatment. So it is a highly treatment-resistant disease. Can give isotretinoin tablet 1 to 2 milligram per kg per day for 5 to 6 months. May cause significant long-lasting remission. So other treatment includes systemic antibiotic, corticosteroids, surgical excision, and grafting can be done. Next one is acne claudius nuchae. It is type of follicular keratosis, a chronic inflammatory process of hair follicle in the nape of neck and occipital area of scalp leading to hypertrophic scarring. Various factors like trauma from razor, friction, tight collars, frequent haircuts, and curvating hair shafts. Infections. The lesions start as small, fresh-colored follicular papules and pustules over the nuchal region and lower occipit. The pathology, the early lesions is the folliculitis and perifolliculitis with predominant lymphocytic and plasma cell infiltrates surrounding the lower half of infundibulum isthmus. In advanced lesions, there are numerous snacked hair follicle trapped with a dense fibrotic matrix associated with the foreign body granulomatous reaction. Treatment, topical corticosteroids can give and topical oral antibiotics doxycycline and laser-based hair removal can be done and surgical excision and cradle lesions. Next one is erosive pustular dermatosis. Disease is commonly seen in elderly women and presents with chronic red, extensive pustular crusted and eroded pustular plaques over the scalp. Pathology, histology shows areas of epidermal erosion with non-specific changes of atrophy and chronic inflammatory and lymphocytic infiltrates, sometimes mixed with plasma cells and foreign body giant cells. Acne necrotica, it is a necroticing folliculitis, mainly involving the scalp margin. The exact cause is not known, though staphylococci and usually cultured from these patients. Papules and pustules erode to form crust, leaving depressed scars. The condition is chronic and recurrent. Secondary alopecia. Uh, First one is tension. Tension due to chronic tension, the hair follicle results in follicle damage and hair loss. The usual cause is cosmetic And cultural practices, tight lips, tight bands, curling, tiny tight ponytails, twisting of uncut and top of hair, and scleroderma. Scleroderma occur in both general and localized forms of scleroderma. Linear pattern over the frontal region of scalp, which is encompass breed. Initially, it presents as erythematosus, non-pitting edematous blocks. Gradually, these lesions develops a waxy yellow colored center with a smoke center and a left border. Histopathology, you can see the chronic inflammation of the hair follicle and thick collagen bundles. In later stage, there is almost disappearance of inflammatory infiltrates with atrophy of the eccrine glands and permanent fibrosis. Sarcoidosis, you can see the nodules first form plaque which spreads peripherally, forming annulation with a depressed patch in the center. Histopathology, you can see the inclusion bodies such as common bodies and asteroid bodies. And main tension point is non-caseating granulomatous pattern. This is an active granuloma. Second is NLD, Necrobasis lipodica. And 10% of cases, the lesions of NLD are present in the areas apart from legs. So legs is the most common site. You can see lesions. Other than that, particularly on the face and scalp, lesions occurred in these areas are often rice and firm and nodular and annular appearance. About 80% of patients are women. Approximately two-thirds are diabetes mellitus. On histopathology, you can see necrotype granulomatous reaction with a lipid deposition may be seen. And there is inflammatory of tinea such as Kiria and Favus. So they both are type of inflammatory of tinea capitis. So how will you approach? You have to do you ask a proper history and do a proper examination. So you have to ask the onset, duration, rate of progression, and associated symptoms such as itching, the pain, or you can have to ask the previous treatment history. You have to ask family history. You have to examine by using dermoscopy. You can do biopsy, and you can do special tests such as stain. You can use a confocal microscopy. So there is this image showing the dermoscopy of DLE. The green arrows represents black dots suggestive of dermal melanin. The yellow arrows corn curls, cumulative leg opening. The red arrows which indicates the patellus follicular openings, and red stars which indicate white stars such as fibrosis. The dermoscopy of LPP. Small and big white dots suggest empty follicular openings, honeycomb pigmentation, and loss of follicular openings. The dermoscopy of follicular decalvans. Um, DEF, it is important in terms to differentiate PCA from LPP. In CCLE, you can show the granulomatous deposits of IgG and C3 of the DEJ. In LPP, there are granular deposits of IgN at the DEJ. So near treatment and transplant including follicular extension therapy. So it's a good promising results. You can give PRP therapy and stem cell solutions have been using. Thank you.